Good morning, everybody. I'm Abdoulaye Seye from UNICEF. Would seize this opportunity offered by Emerging Voice to introduce this presentation talking about the use of bottlenecks analysis approach as an entry point to assess and strengthen decentralized immune system. This case is from Anambra State, which is in Nigeria. Um, to achieve to achieve the vision of no child born with HIV by 2015, Nigeria, which is the most populated country in West and Central Africa, contribute to 29% of the global PMTCT unmet need in terms of number of positive pregnant women who did not receive ARV for PMTCT. Nigeria government commit itself to reduce the burden. So they decide to apply this approach in Anambra State, which is we have a prevalence higher than the national average. What is the bottlenecks analysis? Bottlenecks analysis is a programmatic approach that Nigeria intend to use, but it's sake to improve the performance of the maternal and newborn and child health and PMTCT platform by identifying bottlenecks and barriers and the health system determinants such as the enabling environment, supply and demand side, and quality of services. Applying bottlenecks analysis at the local government areas, LGAs, allow to, first of all, identify the bottlenecks of the high intervention, and then after to identify the disparities between a group of population, and then after to develop action plan, micro action plan to implement high intervention activities, and then after to have monitoring plan or to monitor the bottlenecks. Bottlenecks analysis required reliable and quality data related to health system determinants such as supply, demand, and quality. However, at decentralized level, the health information system, which are the main source of data, are characterized by their limited capacity to provide such quality data. And the Anambra State is not exception. So BNA was used as an entry point to collect data on the key determinant of the health system first of all, and then after to triangulate this data with the main source, other source of data available. This is the state AIDS control agency data, which is a parallel system we will see after in the further in the presentation. And the mix, it is a household survey carried out every 4 years and will provide the main indicators related to PMTCT. Result from this triangulation show that there is many gap between their data sources. For instance, while mix show that more than 93% of pregnant women attend antenatal care one, HMIS report only 29%. HMIS did not report PMTCT data, such as pregnant women who were tested during INC or HIV positive pregnant women receiving ARV for PMTCT. And the SACA system don't collect data on MNCH. This means that the two systems are not supplementary, even they have the same primary data source. For instance, and then when we try to compare the data from LGA by LGA, we see that we show that data that didn't make sense. For example, when you can see antenatal care 1 lower than antenatal care 4. And that is the reason why we decide to go further in this assessment to assess the overall component of the MNE system by using the PDQA. PDQA is the participatory quality data assessment, which involved the M&E officer from the SACA, the M&E officer from the HMIS, and the partner of the Anambra State. And normally, if as you show is this graph, if the system were good, we will have a blue circle. But it is that the fact is here we found that there is many lack of component. Many components are weak, except the existing database. Anambra State have a good database which is in the state level, and every health facilities have M&E officer who report on this data, and it is something very important also for achieving the data. But as I said previously, we noticed that the HMIS and the SACA M&E system are two parallels, while they have the same source of data. And this HMIS is just for the government, and the M&E is mostly led by the. We found also that the existing data that are collected in the HMIS is not used in terms of analyzing, first of all, and used for programming or for decision making. And it is a big gap in terms of using data for programming. And at the end, we found also that the M&E officer from the HMIS have low capacity but are not motivated to do their job, because their counterpart who are in the M&E, the SACA M&E system, risk incentive like motivation from the donors, and while they have to do the same job. So what we can learn in this process in terms of key lesson learned is that, first of all, it is important to strengthen the overall M&E system. But I would emphasize here that it is also very important to build capacity. To build capacity by conducting training and by supervising the M&E officer who is responsible of this system. It will be very important also to try to find innovative way to motivate the M&E officer. We can use recognition awards, provide them laptop to put their data, or bicycle to conduct outreach activities or data collection in the field. And the last key lesson learned is that it is important to have participatory review of data involving all the stakeholders from the Anambra State. It is a way to promote the use of data, to use the data for programming and for decision making. So in terms of take-home message, we can say that the bottlenecks analysis approach is approach planning of the primary health care intervention, but also a strong entry point to strengthen the M&E at decentralized level. But we would recognize that the assessment and the strengthening of the health information system should be an integral part of any data-driven planning process, because without good quality data, we cannot have good planification and good implementation. Thank you very much.